that will not be recorded either. All right. We are very grateful to have Dr. Fenton here today. He's a pediatric surgeon at Primary Children's Hospital in Salt Lake City, Utah. He's also worked to establish a fetal center there to help provide care for pregnant women with prenatal diagnoses of congenital anomalies. He is well-versed on the topic of repair surgery and the different treatment options available for omphalocele. So hopefully the information he shares today will help you all prepare your own little ones for surgery. Before he begins, I want to remind everybody that even though he is a surgeon, he is not your surgeon in most cases, and he's not providing any direct medical advice today. He's here to share his own personal experience with all of us. So please direct your own specific medical questions to your own providers. All right, Dr. Fenton, I will turn it over to you. Oh, you are still, there we go. Oh, no, that was Parker. Dr. Fenton, you are muted.
Yeah, there we go.
There we
For some
go.
reason, the little button wouldn't come back up. All right. Well, I'm very nice to meet all of you. I'm certainly happy that we can talk today. And as Melissa said, I'll give you my perspective from the from care of giant omphaloceles over the past. Well, I've been here in Salt Lake almost 11 years, and I've done pediatric surgery for 13 years. So we'll go from there. And I'm going to share a lot of pictures on here today, just so you guys know. You're all in various degrees and stages. Some have had it repaired, others have just heard about a diagnosis of their unborn child. And so my hope is that we can kind of go through this together and feed off of each other's experiences. So a giant omphalocele, one of the things that's characteristic about it, it's a congenital abdominal wall defect, but it's covered with its amnion. And this is a newborn. You can tell because the amnion is still transparent. You can actually see liver and intestine through it. This is just another picture, another angle of that. You can again see that it's very transparent. And the umbilical cord is hanging off of it. You just can't see it in this picture. This is when it's a few days old. You can start seeing that it begins to opacify or begins to kind of become you can't really see through it, and it develops what we would call eschar or like a big scab over it. So prenatally, as some of you have already brought up, it's diagnosed typically on a screening ultrasound. And here in Salt Lake City, those moms are then referred to our multidisciplinary fetal center, where they're seen by a high-risk maternal fetal medicine doctor, myself or one of my partners from pediatric surgery, neonatologist, social worker, and other subspecialists as needed, as some of these kids can have other congenital problems diagnosed as well. And so we will get an echocardiogram or a heart ultrasound on all of these kids. So if we need to get cardiology involved, we'll get them involved. Here in Salt Lake, we don't routinely perform fetal MRI. Fetal MRI, in some cases, we will perform if there's questions or other diagnoses that we're worried about. Some centers perform routine fetal MRI to get a total fetal lung volume. It kind of gives us an idea as to how sick the child will be. We haven't found here, at least, that it helps us in our postnatal management unless there's questions about other aspects of the kid. But we plan for an in-center delivery, meaning they deliver here at our hospital in order to treat them immediately thereafter. Now, when we talk about treatment, I'll get into that here in a little bit. Some of the associated issues that we have to take care of in these kids is one, pulmonary hypoplasia. So for whatever reason, because the abdominal contents are outside of the abdomen obviously doesn't grow as much as it normally would. But there's also a decrease in growth of the chest, and that decrease in growth leads to underdeveloped lungs. And some of these kids, it can be fairly severe, and they might require either a breathing machine like a ventilator or additional oxygen support. And the NICU has a wide range of different options to help with support, some of which child can go home with, and others obviously it's too high to go home with. Congenital heart disease, again, is something that we worry about. Actually, kids that have smaller defects have a much higher risk. And so, all of the kids that come in that we evaluate, we do an echocardiogram on. We need to take care of the omphalocele up front, whether we're going to close it or not. And then there's other anomalies that we look for in these kids and may have to treat. So this is just a chest X-ray. It shows a very narrow chest. Sometimes it's been referred to as a dog's chest just because it's long and narrow, as if a chest X-ray of a canine. And that's again just demonstration of a very, very underdeveloped lungs. So I kind of want to focus on the surgical management and surgical options of these kids. And again, I when I counsel parents prenatally, I talk to them about all of these options. The caveat always is we're not going to know until the baby's born. So I can assume uh, at times that it's a giant omphalocele, but sometimes when they're or a smaller omphalocele, but sometimes when they're born, based on the stability of the child and then based on how the omphalocele is, will determine what surgical option we will pursue. So there's really three surgical options: primary closure, a staged closure, sometimes called a Schuster, and it can be either sutured or sutureless. And then a third, which is sclerotherapy, or sometimes called paint and wait. So let's talk about primary closure first. Typically, we can do it when it's a smaller defect. Um, uh, we can do it when the child is fairly stable, and we can close them without compromising them physiologically. And I'll talk about that a little bit more as we go along. And then it's not emergent because of that covering on there. So, some parents um, uh, may think or feel that their baby will be operated on emergently after delivery. That's usually not the case. We usually let the child kind of settle and stabilize after delivery. And in most cases, we do it within the first few days of life. And it just depends on how stable the baby is. So this is a baby that we operated on fairly recently. You can see that the child's been prepared for surgery with a scrub. Here's the omphalocele. You can see that it's been a few days because it's darkened, it's not transparent, and here's where the umbilical cord would come off of. And when we first saw this baby prenatally, we figured it would be a giant omphalocele and that we would not be able to close it. But once the baby was born and we looked at it and looked at the baby, we felt like we could close it. And so we were able to close it, I think, on the third or fourth day of life. And we left a drain where we made a new belly button. And then this is the baby that came and saw me in clinic. I would say a couple months um, after we operated on the child. And and so you can see there's a really nice result here as far as the scar and a new belly button. This is another baby again that we saw with what we felt was going to be a giant omphalocele. And the definition of giant omphalocele is a 5 centimeter abdominal defect. So meaning it's 5 centimeters wide, or sometimes another way of defining it is with the liver out of the belly and in the omphalocele. But again, sometimes our ultrasound and even MRI are not perfect at helping us know. And then based on how the baby is and how big the abdomen is, can tell us whether we can really close it safely primarily or not. And so this was closed again, a drain left at the belly button. So I kind of want to skip the stage closure and go to paint and wait, um, uh, um, and just talk about that a little bit. Typically, we do this for giant omphalocele, and it's when you're unable to close completely without compromising the child. So, compromising meaning physiologically. So, they can't undergo surgery because they have a pretty severe cardiac defect. We don't feel like they can undergo surgery because they have pretty bad pulmonary hypoplasia. Or what I would even say is we can close almost all of these kids, but you're going to take a child who may be able to breathe with a little bit of oxygen through the nose and now subject them to a ventilator for weeks. And so, what was once considered what I would call a salvage procedure, meaning didn't feel like we could operate on the child now, so we're going to do wound care and plan on operating on the child later. It's really become our primary approach for giant omphalocele, and I'll explain why in a little bit. So the big thing is how do we care for that wound? Because, like I said, it becomes like a big scab. And so we use Silvadene cream. It has silver in it. It's an antibiotic cream. And we're not trying to keep bacteria from growing on it because bacteria is all over our skin and will grow on the omphalocele as well. What we're trying to do is keep good bacteria growing on it and keep out bad bacteria. So that's what the silver cream helps with. So, what I tell parents is you can wash the omphalocele just like you would the rest of the baby in a bath using mild soap and water. And then after you dry it, you put the Silvadene cream on the healing amnion. So, not where there's new skin, but where the amnion is, where that scar is. And you put it on like you're frosting a cupcake. You cake it on and then there's this non-adherent gauze. Sometimes it's called Adaptic. I think there's another one called Curic or Cutic, which is kind of it covers it and it won't allow the Curlex, which is regular gauze. And I'm going to show you pictures of this here in a minute from sticking to it. And then we use a 3M Coban wrap to add support. And we're trying to add a little bit of pressure to it just so it doesn't grow, allowing it to go on its own back into the abdomen. And what I tell parents is I want you to make the omphalocele kind of like a Coke can. You want to keep it like a Coke can and let the omphalocele drop in on itself. So this is kind of what we use, the Silvadene, the non-adherent gauze, this Curlex gauze, and then Coban. And this is how we wrap it. So initially you'd have the omphalocele and it would have the Silvadene Adaptic and then the white Curlex. And I start at the base and we wrap around and then we go around the back and around the base and around the back and around the base to kind of hold it in place there. And then we do the same thing with Coban. Now, this is one that a parent did. Usually, when they come back and see me in clinic, they've become masters and pros at it, and they make it look beautiful and pretty like this, much better than I could do. Now, why do we want to keep it like a Coke can? Well, this is a baby who, for kind of one reason or another, kind of slipped through the cracks, if you will, and didn't have follow-up that we would have wanted. And you can see how big the omphalocele has become. As the baby has grown, the omphalocele has grown. And what we really want to try and do is keep the omphalocele the same size and let the baby grow. And as the baby grows and the omphalocele stays the same size, it will eventually drop in. Um, This is actually, I like showing this picture. This is a crew actually a while ago, as you can see. And what I like about it is you can give these babies tummy time in order to, even with the omphalocele. And I think that that's important. What I tell parents is I want you to treat them like normal kids, even though they have an omphalocele. Let them go through the developmental milestones that they do. And we've seen kids, as you guys know, with omphaloceles crawling and walking and kind of go through all the normal stages of development. So here are just some pictures for those of you that haven't seen them. This is at 3 weeks, and you can see there's the eschar or the scab, and then there's this granulation tissue. This is new tissue that's starting to form, and it kind of forms these islands, and weird things happen to it. You see blisters where it wasn't, and it kind of all goes through this transformation until it's all covered, and the skin actually starts down low at the base and then works its way up to the top. And typically, the last place to epithelialize or get skin is where that umbilical cord comes off. And so, what I tell parents is when you're in this stage, you don't need to use Silvadene anymore. Use lotion. Use baby lotion and just keep it nice and moisturized. So now you can see at 12 months, it's fallen in. And there's a range as to when it happens. I've had some kids where it's fallen in as early as 3 months. I've had other kids where it's taken upwards of 24 or 36 months to fall in. There's a wide range. I would say if you can keep it kind of as that Coke can, and with a little gentle compression, as the kid's body grows, it'll accommodate it and it'll fall in. And then here you can see we had to wait even a little bit longer in this one, 18 months. And it's pretty small. And once it falls in, then I tell parents to get an ACE wrap and just wrap it around the baby to hold it in place, just to hold the omphalocele in. You don't have to do it tight, but you just want to have a little bit of pressure on it so when they're up and about, it's not pushing out. And people say, well, the ACE wrap goes up and down. And I say, yeah, that's true. So you get a little 3M blue tape. There's this blue tape you can get on Amazon called 3M blue tape. It's amazing because it sticks really well, but it comes off easily. And if you just put a little piece up top and a little piece down low, it'll help keep that ACE wrap in place. So here you can see this. Now, this is a really, really probably the biggest omphalocele I've seen. We're still taking care of this kid. We've not closed this yet. You can see again just the different stages. And now we start seeing it start falling in. It looks like a gnome's cap, and that's because that tip is all this redundant skin, and the contents are actually here and starting to go in. So, we're making progress, but again, even these really, really big ones, you can get to fall in with time. You just have to be patient. Now, most of the time, we send our patients home with a little turtle shell, and that's just protection, not so much for parents, because you guys are always very cognizant of this, but maybe for visitors or siblings. And, they wear them to variable degrees. It's obviously hard. As they grow, the turtle shell will become too small. And once it's in, it's not really needed all that much anymore. So let's talk about final closure. I usually tell parents it's going to be somewhere between 6 to 24 months. It depends on the baby, depends on physiology, how well the baby's doing, depends on how long it takes for it to fall in. And sometimes after it falls in, some of these kids may have problems with feedings after. So they might have been eating just fine, but now that it's inside, some things might be compressed. And so we may need to add a feeding tube to help with feeds. And when it falls in, we usually have to wait a few months before we can really fix it because we need that belly to get used to having all those things in there and grow a little bit more in order to close it. And then that tissue, so I'm just going to go back, all this tissue right here, we can't really use that for closure. So, in some of these kids, we may need to have our plastic surgeons put in a tissue expander to get good skin in order to help close. And so, it might again be several months after it falls in before we can close it. And I usually tell parents you should plan on about a 2 to 4 day hospitalization after. I think probably I usually say 5 to 7. It just depends how the child is doing beforehand. So I'm going to show you some pictures here. Again, that skin needs to come out. We can't really use it. We close the muscle up. That's the muscle closure. And in this baby, they required a G tube, a gastrostomy tube. Most kids, I would say, don't, but I have some that do require a gastrostomy tube, and we'll do it at the time of closure. And then in some of these kids, I have our plastic surgeons come in and help me recreate a new belly button. I usually do it on my own. In the kids, I can close primarily, but I like the plastic surgeons to help me with closure, especially when this is required. This is the tissues expander. These little bumps right here are the ports. So they put the expanders in, and then they have to put a needle into the port, sometimes on a weekly or every other weekly basis, to add saline to those tissue expanders to pump them up to help this normal skin grow. So you can imagine that that will take a few months to do, because all this skin that's marked out here is going to need to be removed. And so here we are with the muscle closed, and there's the closure. I think that was actually a different one, but here's just a couple other closures. This is probably one of the best belly buttons I've seen our plastic surgeons do, and it was so good when I saw the kid. I think this is a couple years later. I took a picture and sent it to our plastic surgeon and said, please continue to do a belly button like this. I think they look awesome. So just so you know, I tell all parents that there's probably going to need to be revisional surgery at some point, maybe for a hernia, either in the groin area if we can't do it at the same time, or along the abdominal wall. And in some cases, there may need to be a revision of a belly button. So, what are the issues? Well, we got to take care of that wound for a long time before. And some of our parents have run into people asking what the heck their kid has there on the belly when they're at the grocery store or other areas. So, there's some stigma along with it. I think from a developmental milestone standpoint, like I said, most can start moving forward despite that omphalocele. And I think that is important because I think with paint and weight or sclerotherapy, you guys and the child kind of pay up front. You have to deal with the wound. You have to, kind of continue to move forward in life with this big kind of abnormal belly. Now let's talk about a stage closure or a Schuster because a lot of centers across the country offer this. When I came to Salt Lake City, I had been trained on the Schuster, and it was what I felt like initially was the best thing to do. So what is it? It's an amnio inversion where you actually push the whole omphalocele in over time to it under the muscle. You close the muscle and then close the skin. It typically requires several surgeries, most of which have to be done under general anesthesia. There is some sutureless where people are doing it more and more at the bedside without surgery. But I would say it does lead to physiologic compromise, mainly with increased belly pressure, which puts pressure on the heart and on the diaphragm. So you have to wait for the kids to overcome that compromise in order to push it in further. And that's why it takes so long. And again, it can be done sutureless at the bedside, but you get the same physiologic consequences. So this is just an early paper showing that amnio inversion. You actually have to separate the skin from the amnion, and we sew some mesh to the underlying muscles and then gradually push it in. I'm going to show you some pictures Here's a giant omphalocele, really big in a small kid. So here I'm just showing you how we've separate the amnion's now underneath the mesh. This is the muscle. We're going to sew the muscle to the mesh here. And you can see the skin is just kind of overlying it. And then what we do is we start tightening it up. So here's our sutures to tighten the mesh. We just cut that excess stuff off. Then we use a special dressing for the kid to go back to the NICU just to try and keep it clean. And when they've kind of overcome that physiologic compromise, we go back to the operating room and we push it in more until we can close them. Now, this is when I used to do drains outside the belly button. I really like to put the exit side of the drains in what I want to make the new belly button because I think it makes it look nicer. This is another omphalocele. You can see it's several days old because of how the amnion looks. Again, this is a really big one. And you can see, I'm going to show you stages of it going in. This is each time in the operating room until we can close it. This one, I would converted what I would say this kid from an omphalocele into a scrotocele. So most boys with omphaloceles will have inguinal hernias. I typically do not fix the inguinal hernias at the same time of the omphalocele because it's going to be a much higher chance of the hernias coming back. And so I usually tell parents we're going to fix those hernias at a later date. So the problem oftentimes with doing this is you're going to start seeing wound breakdown. It's just a lot of pressure on these kids. They stay on the ventilator for a long time. Because they're on the ventilator or high flow oxygen, they can't eat, so they oftentimes have tube feeds. And this is one of the big things that we worry about. This is a kid that I did a Schuster on when I first got here, several months later in clinic. And he ended up having his hernias fixed and ultimately did well. This is a child that I was referred to by my partner who had started a Schuster. And when I saw her, I just felt like we should not do this. I didn't feel like it was the right thing to do for her, that it was going to take way too long. And so we converted it back just to paint and wait. And we did paint and wait. She went home, and here she is in clinic. She may need a little revision of her belly button. We'll see. But, I mean, this is her at 2 years old. She's probably closer to 5 years old now and doing really, really well. So for me, the issues with the Schuster is longer hospitalizations. We're really looking at least 2 to 6 months when they're in the hospital. I think in some of the studies, the average is about 70 days. Prolonged ventilatory requirements. Some of these kids will require tracheostomies. Feeding intolerance because they're not eating, so they get oral inversion. They have long-term feeding tube supplementation. And then being on a ventilator and being in the NICU for that period of time is not always good for the developing brain. So I usually say in these kids, when you do the Schuster, you pay later. And so I know every parent wants their baby to be perfect. I have 4 kids. And what I usually say with a giant omphalocele is we can get you there. You're going to have to pay one way or the other. You either pay early or you pay later. And in my mind, with a giant omphalocele, paying early is dealing with the wound, dealing with the stigma, helping that child develop with a giant omphalocele. But ultimately, most of those kids, at least in our experience, will go home typically within a month. Parents learn how to do the wound care. We follow along with them pretty closely in clinic. And most of those kids, will be able to close probably within 12 to 18 months. I think that's on average. We certainly, again, have some kids that I've closed as early as 6 months and other kids that we've had to deal with or close much later based on other issues. But most of those kids progress pretty darn normally otherwise. And I'm not saying that kids that undergo a Schuster can't get to that point. It's just delayed. They usually have feeding issues. They usually have respiratory problems. There are issues again with being in a NICU for a long, long time. And so, overall, I would say I give all three options to parents and then really that will determine what we do once that child is born. So don't hold me to any one of those options because we really don't know until the baby's born. And I can go and look at them bedside, give them a little squeeze, see how things go in, and determine how stable they are from a breathing standpoint or other aspect standpoint, talking to our neonatologist and decide whether this is someone that we should pursue sclerotherapy on or whether we can close sooner. And certainly we've had some kids where I think, gosh, it's, if we just maybe do a couple, it might take us two in order to close, but we're going to get the child closed and then get them home. We'll certainly consider that. But I think in most cases, what we're doing, and in talking to a lot of my colleagues across the country, most are probably either doing primary closure or sclerotherapy. So that's the presentation I have. I'm happy to now answer any questions that you guys might have about what we've just talked about.